are excited to have Dr. David Linehan, who's a co-founder and CEO of Tiber Health. He's driven by the relentless commitment to making medical education more accessible for students of all backgrounds and income levels. An experienced educator and a medical practitioner, he has witnessed firsthand the limitations of the traditional medical school model and resolved to create a better, more inclusive and effective. The Tiber model is inspired by students at Ponce Health Sciences University in Puerto Rico, where Dr. Lenihan serves as president, and Tura College of Osteopathic Medicine in New York, where he served as dean. Dr. Lenihan has fundamentally changed the way medical education is taught. By flipping the classroom real time, he created a model that reduces costs while improving quality, graduation rates, and US board scores.
My name is Dr. Dave Linehan, and I'm the president and CEO of Tiber Health. We took over the school in 2014 and instituted a technology revamp program. And the idea behind this was, how do we expand our curriculum, our digital curriculum? And I'll tell you a little bit about why this got created. When I was dean at Toro up in New York, our mission was to expand the access of healthcare to people from lower socioeconomic backgrounds. At that time, we were talking about underrepresented minorities. And we really didn't have a good mechanism for identifying students. We all know that the MCAT and even GPA can be, excuse me, very unreliable in trying to select students. And so when we talk about this stuff, it's how we use this information to help us with our curriculum and our admissions process. And I gave this lecture on the blood supply to the brain. I teach neurology, and these are freshmen, first-year medical students. And for 2 hours, I went through the 3 vessels to the brain. There's a front, middle, and back. And at the end of that class, I said, all right, here's a patient that has had a stroke. Which vessel was damaged? The front, middle, and back. And they had those student response systems. And I got about 25% A, B, C, and D was a made-up answer. So it showed me that they really didn't know what I was talking about. And I kind of got upset. And I said to the students, I go, look, you're all going to see this patient in a couple years when you're in your ER clinic, and you need to know the answer. And so I said, you got 3 minutes to figure it out. And the great thing about medical students is if it's worth points, it's worth more than money, and they're all in. And so they go figure it out, and they all got the middle cerebral artery, which is where most strokes happen. And we went on with the course. And I left the course, and I thought, all right, there's a problem here. Either this 150 students in the classroom are just too dumb to understand a really smart guy like me. I mean, I went to Cambridge and Edinburgh. I'm super duper smart. Maybe that's the answer, but probably not. The answer was, what if I'm not a very good teacher? What if I wasn't connecting with the students? And that's a real tough rationalization for a professor to make. And so what I did was I can move my screen here. I went through and I recorded my lectures. So I recorded my lectures and I put these things up. And at first I did those with sound, because this is back when Blackboard was just getting accustomed to doing this. And the students would come to class, and what we would do is work through clinical problems. I started doing this in about 2007. And what happened was we started collecting all this information from the classroom. We started getting tons and tons of data on what the students did know, what they didn't know in the classroom, along with how they took that information on exams. And so we started just building this giant database of how students responded to stuff, when it happened in timelines along the curriculum, not knowing what we were going to do with it. But the students really liked learning in this method where they would sit at home, watch the lectures, come to class, work through problems. And at first I had a lot of trouble convincing the faculty to do this, because they all wanted to stay in their, we stand in front of the class, we give a lecture, the students listen and take notes. But eventually, as it kind of happened and the faculty got accustomed to it, we were able to move it around. And the things we really noticed about why this was effective was it helped us reduce the price, which you'll see at the end of this. And the reason it was helping us reduce the price is because we could use lectures that were good, throw away lectures that were bad. And it also reduced our risk of faculty. We've all been in a school where a faculty member calls in sick or something happens or they quit. This allowed us to make sure we had all that educational material lined up, outlined, and examined. So we had all the exam questions before the year actually began. But what happened was, as we started getting all this data, what I started to know is that it started to form a pattern. And the pattern was students behave like equity markets. When I mean equity markets, I mean the stock market. And what we did is we started to look at how difficult questions were. We looked at things like Cooter-Richardson ratios by serial numbers. And what we did was we calculated money, because everyone understands money. Each question, we calculated how much money it was worth. And if the student got the question correct, we would put money into their bank account. This is virtual money, not real money, but we put money into their account. And if they got it wrong, we took it away. And we track them like the stock market. So we would just track them like the stock market. And over time, we were able to set patterns. We were able to say, all right, what are these predictive models? And what we ended up doing was we used E-Trade, which is a company here in the United States. We used their equity yield spread curves and drew a regression line down on this. What we were able to do with an R of about 0.85, which is a highly statistic number, by about 3 months into their medical school, we were able to start predicting what their step 1 scores were going to be 18 months later. I want you to think about that for a second. We're 3 months into their medical school. I'm able to start predicting what their step score is going to be. So we could start guiding them into residency programs. If it looked like they were going to get a 205 on step 1 and they wanted to do dermatology at Hopkins, we were able to reassess that viewpoint and say, hey, look, maybe we should be looking at a different discipline and not derm. And it allowed the students to kind of get an understanding of what their skill sets were and what they were likely to be able to go into in a residency program. The second thing we were able to do is start changing our admission standards. One of the things we looked at is the MCAT. We learned that the verbal score was highly dyselective to African Americans and Hispanic students. We learned that the freshman and sophomore year of university were not very predictive on how they would do in medical school. And when we did this, our applicant pool blossomed. And we started taking students that none of the other medical schools would take. Our URM ratio, which is Black and Hispanic, went from 3%, which is about the US average, to over 40. And we had some of the highest board passage rates in the United States. Again, taking students that no one else looked at, taking students often from lower socioeconomic backgrounds that no other school looked at, and getting them into the medical profession. And the reason we're able to do that is because we built this large-scale data analytics. And when we look at these data points, we're looking at tens of billions of data points. Every time we ask a question, we calculate out 29 reference points to these things. By the time the student finishes about 4 semesters in medical school, they've answered about 10,000 questions. To the 29th power becomes a very large number. And that's how that predictive model became. And when we went forward with this, what we then started to be able to do is look at how that student performance was actually going on. And we were able to break it down into all the LCME categories, cardiovascular, physiology. By the way, we found that physiology is the most relevant or most predictive course and model to the USMLE, probably because it's so pervasive across. But we're able to build out these predictive models looking at data. We've now taken this one step further and we've created a master's program. And the master's program is the first year of medical school for students who did not get into medical school. And we run them through the first year of medical school. And the reason this is important is medical school is not hard. Medical school is just a lot of information thrown at you at a very fast pace. And what we found is about 30% of the students who did not get into medical school because some admissions counselors saw that they got a C freshman year and should no longer be a doctor. We take those students into this program and we run them through the first year of medical school. And because we have this regression data set from real medical students that are already in school, and we know what those board scores are, we're able to identify about 30% of this population of students that did not get into medical school that will become great doctors. Every student we've taken from this program over the last 5 years has passed the boards. Think about that. These are students that never got into medical school. No one even looked at them. They didn't even get interviews. And now we're able to take them into our school and get them into a medical education and get them through. And the reason this is important is in the Midwest of the United States, from West Virginia to Colorado, there is a massive shortage of, one, physicians, and two, there's a massive shortage of diversification of our physician workforce. I don't talk about race, but we do talk about socioeconomic class. And we need to start taking more students from rural America and urban core America. And when we do that, this is what this program does. We bring them in and we're able to start predicting what their step one scores is or will be before they even get into medical school. And that's kind of what this graph here is looking at. It's looking at students. This is actually this year's stuff. So these are de-identified students and what their step scores would be. And we find that's very important to when we select students into the medical school. And we're also giving this information to other medical schools because pretty much most of the medical schools in the Midwest are having a lot of trouble getting different or more diversification in their workforce. And so what's this allow us to do? Our average GPA coming into our school is 3.2. And I know I've spoken to medical school deans and they go, the horror of horrors. I can't believe you don't take a 3.7 GPA. Your kids aren't as smart. Well, I'm happy to report this year we have 100% board passage rate. We're taking students that none of the other schools took and getting them through at a better board passage rate. And the reason this is important is because our students are the ones that are going to go practice in areas of need. Our students are the ones that are going to go into places where we actually need doctors. We got enough doctors in New York, Miami, enough doctors in LA. We do not have enough in upstate New York, in rural America, in urban core, Rust Belt, Midwestern cities. And that's what we're actually trying to do. But here's one of the things I think is most important. Our cost is over half what the other schools are. Because we've been able to digitize the curriculum, we've been able to keep our costs down. Our students earn less than 2.5 times the average medical student's income. Our students' parents earn less than $40,000. Most medical students' parents earn $100,000. And you can't charge massive amounts of tuition. Most medical schools are charging up to $70,000 now. That's outrageous. Students can't afford that. We need to get these costs down. And the last thing, because we're all talking about COVID, I will say that because we digitized the curriculum in 2014 in Ponce, not knowing that there was a COVID coming or there was going to be a pandemic, when this actually happened, our attendance went up 6%. It's because the students already knew how to do that. If you're a medical school dean, if you're in this and you're into this to disrupt, you're not preparing for what this pandemic is right now. If you're doing that, you're scrambling. As innovators, as disruptors, we need to be thinking, how do we improve our curriculum, our content, so that when the next situation happens, that we're prepared and that our students are going to be educated to a level that's going to be able to provide care for our future families. And that's what we're trying to do. Keep the costs down, increase the technology, improve the diversification, and get more doctors in that are going to go practice in areas of needs across the United States. That's what Tiber does, what I try to do every day. And that's it. Thanks, Amir.
Wow, David, that's really fantastic. I mean, you're really leveraging technology, data, all the points, and really, I think, transforming how taking that traditional medical education system and turning it upside down. So, that's great. First question, I think, is from an Indian context, David. You know, you talked about. I think your program that you built is fantastic, and it's allowing costs of education to come down, allowing personalized more way for more success of the student through tool sets and data, which is that seems like the way future of education should go. What do you think about bringing? I mean, for students in India, right? Or bringing that kind of technology to to the Indian market, so that we need a lot of doctors, we need a lot of nurses. So to actually create that supply, of professionals?
Yeah, so one of the things we're looking at is we're getting ready to expand internationally. So a couple little people PM'd me here about that. What we're looking to do is as we build out into different parts of the world, because we have the technology ready to deploy, once we get accreditation, we can be operational within a week. And so it's really quick. And the idea is this is what I'm looking at a little bit from an American perspective, but this could go anywhere, is as we build a school out in North Africa, let's say, and we have Somali students coming into there, I'll be able to identify how those students would do on the STEP scores in the United States. And if it looks like they're going to do well in the boards, we'll bring them into the US to do their clinicals. And then when they pass, what we'll do is we'll place them into Minneapolis, St. Paul, right? Where there's a large Somali population, 150,000 Somalis in the ACO. And so we meet that cultural competency aspect. They'll understand the diet, the religion, how they do that, and how we make money on that. Because the reality is in healthcare, it's a lot of money. People often don't want to talk about it, but they'll talk about it privately. How we make money is we don't charge for that. What we do is we want a cut of the increased revenue they're going to get from the government for better outcomes. So we're putting all the risk on ourselves. If we don't produce better outcomes, if we don't produce better patient satisfaction, we don't get paid. But I know we will. And so we take a revenue stream from that improved reimbursement rates from CMS. The health system doesn't mind because it's not really any money out of their pocket. It's extra revenue they weren't expecting. And I get to help improve the health workforce and health outcomes in the United States. So I think we're going to do that in India. We're looking at UAE. The problems with some of these, Samir, in all fairness, the problems with a lot of these jurisdictions is accreditation. You can show them all the cool stuff you got and how you're going to make it better, but sometimes you got to walk through the hoops on accreditation. And so I'm extremely interested in India. You know that. We've chatted on that. And so as soon as I can get through some of those hoops, we'll be there with this model.
I think that this is the kind of models we need to really transform education here. Thanks a lot.